I am Corey Gusland, Principal and Consulting Actuary with Milliman. I primarily work with provider organizations, accountable care organizations, basically provider entities taking on risk. My area of expertise is value-based payment models. And the topic of this 10 minutes is accountable care organizations, perspectives, and incentives. So Bruce Pyenson asked me to talk about how do ACOs think about their risk options. I'm going to try to answer that question, but also connect it to the broader workshop question, which is, would ACOs be willing to take on risk for a pilot program, such as centered around population health interventions or healthcare screenings? So the way we're going to walk through the talk today is talk about Medicare ACO basics. Bruce has already touched on those a bit. Then get into the economics and incentive structures with those, and wrap up with exploring some of the questions around incentive structures. Do those encourage investment, and in things such as population health interventions and cancer screenings? So let's talk about Medicare ACO basics. So Bruce already covered this a little bit and talked about what an accountable care organization is. I just want to emphasize a few things in terms of ACO basics. First of all, what an ACO is. There's a lot of variation, and the incentive structure and economics is going to vary based on that organization characteristic. For example, if it's primarily just made up of physicians, or whether or not there's a hospitals and health systems affiliated with it, or maybe there's even an outside entity like an ACO aggregator, that will vary and change the incentive and economic structure. So something to keep in mind there. In terms of what population an accountable care organization is accountable for, it's typically a broad population based on which patients the doctors that make up their ACO are seeing. But I do want to note that this oftentimes does include cancer patients. So very much today's discussion is relevant to ACOs. And then in terms of what services are they accountable for, it is Part A and B services, not Part D for Medicare ACO programs. For non-Medicare ACO programs, they're like Medicare Advantage or commercial, sometimes retail drugs or Part D expenses are included. But it is very important to know that Part D is not included, particularly when you're talking about accountability with things like cancer care. So how does CMS define value in Medicare ACO programs? And value is often defined based on measurement against the financial benchmark. The financial benchmark is comprised of really two components. One, it's the historical baseline expenditures for an ACO, and the other is it's the regional performance that an ACO provides services in. So that, got this somewhat simplified representation of the formula, although it's still somewhat complex. But the key thing to note is there's multiple years of experience and expenditures that goes into setting what a accountable care organization's target is. And then that historical experience is oftentimes compared to regional expenditures to make an adjustment based on ACO regional efficiency. What this boils down to is that ACOs are basically competing against themselves to a certain extent, and also competing against their region. And so the economics and incentive structure is largely driven off of that. There's a lot of implications. The second point I want to make is that a key component of any financial benchmark methodology is that baseline or benchmark period used to set the target, does that move over time? And in Medicare Shared Savings Program, it is fixed for the agreement period, which is right now 5 years in length. So there is an opportunity, if interventions drive value, that some of that value could be captured and realized by the entity driving that value over a multi-year period. That's not always the case in other ACO programs outside of Medicare, but it's something to keep in mind because it has implications, maybe something we can discuss later on. So what does the incentive structure look like for Medicare ACOs? What are the program and risk options that they have to choose from? The two main programs that they've typically had an option of is to join CMS's flagship program, Medicare Shared Savings Program, where a majority of ACOs reside. And then there are pilot programs that are testing new ways to deliver care and pay for care that come out of CMMI. Within these programs, within each of these programs, so right now, what we've got here in blue, we've got Medicare Shared Savings Program, and then green, we have direct contracting, that direct contracting program. these are the options that ACOs are deciding on for years 2022 and beyond. If you think about what are the risk options within those programs, we've got those highlighted in this table on the shared savings rate, and then and then we've got shared loss rate in the second row from the bottom. And you can see that if they are to be able to beat their financial benchmark, they could share in anywhere between 40 all the way up to 100%, depending on which program and risk track they select. Shared loss rate, in some instances, if they have a limited time period to be an upside only, where they don't have any downside exposure. But after that, they're going to be exposed anywhere from 30 to 100% of risk. So there's meaningful incentives with these programs. And so going back to that central question, which is how do they select amongst all these competing program and risk options? Typically, when we're working with them, they're bringing us to help them figure out which program do they have the greatest likelihood of success in, and in which program are they going to have the most upside without exposing themselves to downside risk beyond what their risk tolerance is. So that's oftentimes how we work with them, and hopefully gives you a better understanding of some of the economics in play. So to wrap up, we want to go through a few questions here that are relevant to the broader agenda with the workshop. The biggest one being, does an ACO incentive structure encourage investment in population health interventions? And then I'm going to go through each one of these questions that Bruce provided for me in the agenda. So how does an ACO think about population health interventions such as screening? Is it prominent? Is it on their radar screen? I would say, for the most part, no, I don't see it very high on the list. The two things that come to mind that they're oftentimes thinking about is the quality metrics. Sometimes those do include screening, but those that CMS or any other payer that they're contracting with give them, but also they're focused on total cost of care reductions. However, there are lots of opportunities to reduce expenditures. And because of that, they're oftentimes doing some type of analysis or review to prioritize and have a few areas of focus. Those areas of focus, I'm most typically hearing things like post-acute care management, avoidance of ED utilization, site of service shift. Those are the things that come to mind. I don't hear things like thoracic screening oftentimes prioritized within that list. There's lots of competing priorities, and they oftentimes seem to focus on just a handful of things, and that doesn't seem high up on the radar, at least what I'm hearing at this moment. Next question, which is, would an organization be willing to take on risk for such a demonstration or program? I'd answer this two ways. Firstly, within the ACO program construct, and then second, as maybe a pilot that's run outside of this. Within the ACO program, I do think the incentives are there, as we've showed you earlier today. If the cost of putting these in and paying for these, and within a few year period could be realized through offset expenditures, I think there is potentially a case to be made there. There is an element of whether or not, when they avoid these costs associated with it, how that has implications on the financial benchmark. And it gets a little bit complicated, but I think there is a compelling business case there. And that one challenge, though, would be the population that they would potentially, even within a large ACO, what percentage of the population this would impact. And it go back to the response to question one, is it might not be high enough up on the radar versus other competing priorities. But I think there is maybe some hope there. If thinking about a pilot like what Bruce has put as the straw dog example, and is this something that could be considered there? I think there might be some openness. I think they'd probably bias. I'd bias towards thinking that integrated delivery systems and multi-specialty groups would be with that focus on providing care for oncology and cancer actively. Patients with active treatment of cancer would probably be more biased towards participating in this. But I have seen a lot of uptake from those groups in programs like bundled payment programs and oncology care models. So I think there could be some interest. Third and final question, do ACOs ever think about trying to get CMS funding for their own design that doesn't fit into one of these standards? I'd say this seems a little bit more focused and more specific than what I'm used to them pushing and advocating for with CMS, at least the ACO groups that I work with. However, this seems like more of something that I'd expect to come out of the physician-focused model, technical advisory committee, PTAC, that they've had a lot of great proposals, as many of you might know. I don't think any of them have actually been acted on by CMS or CMMI, but it seems like something that would come out of more of that group. But it's a little bit more focused than what I'm used to. I'm used to them talking about more broader program changes and or more just technical tweaks to the existing ACO program, which isn't nearly as focused as what we're talking about today. So hopefully this gives you some additional background, gives you some ideas about how ACOs think about their risk options, and look forward to discussing with you. Thank you so much.